Hey everyone, welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Aylin, your host, and with me today is Joudy.
Hey Eileen.
Ready to jump into some high yield ENT pathology?
Definitely. Today's episode is all about the proliferative and neoplastic lesions of the larynx and nasopharynx. We'll be discussing 4 interesting conditions, each starting with a patient case.
Perfect, let's get started. But before we begin, quick refresher the larynx is divided into 3 regions.
That's right. We've got the supraglottis from the laryngeal inlet until the false cords. Then the glottis, which houses the true vocal cords and controls phonation. And finally, the subglottis from the bottom of the glottis down to the first tracheal ring.
So, what do we have as our first case?
Our first patient, a 32-year-old professional singer, presents with progressive hoarseness. She's been performing daily and notices her voice quality getting worse over time. On laryngoscopy, small symmetric lesions are seen on the true vocal cords.
Classic singer's nodules. Let's define what's going on.
These are called reactive vocal cord nodules, also known as singer's nodes. They're benign lesions on the true vocal cords caused by chronic irritation.
And they're common in?
Singers, obviously, and in smokers too. Basically, anyone with frequent vocal cord strain.
And histologically, what's inside these nodules?
Histologically, they contain a fibrovascular core covered by squamous epithelium. They're small, just a few millimeters, and may be sessile or pedunculated, sometimes with ulceration.
So progressive hoarseness is the big giveaway?
Exactly. That and their location on the true cords, which is key. And luckily, there's no risk of malignant transformation.
Perfect! Let's jump into the next one, which has a viral twist.
Our patient, a 5-year-old child, is brought in by his parents for persistent hoarseness. They say this is his second episode of having small growths removed from his vocal cords. On laryngoscopy, multiple raspberry-like lesions are seen on his true vocal cords.
This sounds like laryngeal papillomatosis.
Yep, it's a squamous papilloma. These are benign growths that affect the true vocal cords.
And the cause here is?
Well, HPV types 6 and 11. In adults, it's usually just one papilloma. However, in kids, they get multiple and they recur. And in that case, we call it papillomatosis.
And it's vertically transmitted from the mother during childbirth?
Exactly. That's why the HPV vaccine matters, actually.
What can we see under the microscope?
Well, these lesions are papillomas, so like any papilloma, they are made of finger-like outgrowths with a fibrovascular core surrounded by squamous epithelium.
How can we spot them?
You need to look for progressive hoarseness, ulceration, and recurrence. The lesions are usually up to 1 centimeter and have a raspberry-like appearance on the true cords.
So the child just keeps having them? Do they eventually go away?
Luckily, yes. They often regress spontaneously at puberty, and while recurrence is common, carcinomas are rare.
Alright, deep breath because now we're moving on to the big one. A 63-year-old heavy smoker coming in with hoarseness, pain swallowing, and even some bloody coughing. Endoscopy shows a nasty ulcerated mass on his glottis.
That's the classic laryngeal squamous cell carcinoma.
And this is a malignant one, right? Because it's called carcinoma.
Exactly. A malignant tumor of the laryngeal mucosa.
Let me guess, smoking.
Absolutely. Major risk factors are smoking, alcohol, asbestos exposure, and radiation. Also, HPV is linked to about 15% of cases, and those patients have a better prognosis.
And how does it usually develop?
Well, it follows the hyperplasia to carcinoma sequence. Grossly, it starts as pearly gray thickenings and can later become fungating, ulcerated masses.
And where in the larynx do these tumors usually pop up?
Mostly the glottis, about 60 to 75% of cases. Supraglottis makes up 25 to 40%, and subglottis is less than 5%.
Alright, so most are in the glottis and very few are in the subglottis. What about the prognosis?
Glottic tumors have the best outcomes because they present early, are often well differentiated, and have poor lymphatic drainage.
So basically, patients with glottic tumors start to experience symptoms before the tumor gets too advanced, so we can catch it and get it out before it's too late.
Exactly. On the other hand, supraglottic carcinoma arises in an area rich in lymphatic drainage, so it's way more likely to spread to nodes early.
What about the subglottic carcinoma?
Ooh, that one's sneaky. It remains clinically silent until it's advanced, which unfortunately delays diagnosis. If it's caught early, though, which is not usually the case, the 5-year survival is over 90%.
All right, time to move on to the nasopharynx for our final boss. So, a 42-year-old man from southern China comes in with nasal obstruction, mild nosebleeds, and a painless neck mass. Imaging shows a tumor in the nasopharynx.
That's the classic nasopharyngeal carcinoma.
And that's another malignant one, right?
Yep, a rare malignancy of the nasopharyngeal mucosa.
EBV?
Bingo. It's linked to Epstein-Barr virus, especially types 2 and 3 carcinomas.
What can be a population pattern to look out for?
So like in our case, it was a Chinese adult. However, in Africa, it's more in children, and in the rest of the world, it's usually bimodal.
And what does this virus do exactly?
It infects epithelium and B lymphocytes, integrates its genome, and activates NFKB, driving malignant transformation.
And are there different types of this carcinoma?
Yes, there are actually 3 recognized types. The first one is keratinizing squamous cell carcinoma, the second one is non-keratinizing squamous cell carcinoma, and the third one is undifferentiated carcinoma, also known as lymphoepithelioma.
What is the most distinguishing feature of the undifferentiated one?
I'm glad you asked that, Aylin. In lymphoepithelioma, aka undifferentiated carcinoma, you can see that cells appear like they're connected in a way, or in a syncytium.
These nasopharyngeal carcinomas are often silent?
Yes, they keep growing for a long time before we detect them, so most already have cervical node metastasis by the time they're diagnosed. Good news though, these tumors are radiosensitive.
What about the prognosis?
5-year survival is around 50%, and to treat it, we have newer options like immune checkpoint inhibitors.
Okay, Joudy, let's go to your favorite part, recapping all of these conditions in rapid fire style.
Sure, let's go. Benign bumps from vocal abuse.
Reactive nodules.
HPV 6 and 11 raspberry growths on cords.
Laryngeal squamous cell carcinoma.
Try again.
Oh, squamous papillomas.
Yep. Next question. What is mostly smoking related? Best prognosis if glottic?
This one's the laryngeal squamous cell carcinoma.
How about EBV-linked, silent, but radiosensitive?
Nasopharyngeal carcinoma.
See? You've got the hang of it.
Ladies and gentlemen, that wraps up our dive into laryngeal and nasopharyngeal lesions. Thank you for joining us today, Joudy.
Thank you for having me.
And thank you everyone for tuning in. Catch you in the next one.